So the next speaker would be Dr. Abigail Colson. Abby, are you with us right now?
Yeah, I'm here. Thank you.
Good, great. So we are with you.
Great. Well, thank you so much for inviting me to be a part of this webinar today. And now I'll be talking about something quite different from the experience of the last two presenters. I'm going to be talking about a project to develop a protocol or guidance or protocol for using structured expert elicitation methods in healthcare decision-making. Next slide. So of course, expert judgments are inevitable in healthcare decision-making. They're used when either empirical evidence is unsuitable or just outright doesn't exist. A common case where this is needed is if there was clinical trial evidence that was gathered from using a treatment in one population, but then decision makers need to make a decision about whether that treatment should be extended to a slightly different population. It's also used increasingly in things like early stage cost effectiveness or to make decisions around rare and emerging diseases where there just isn't a lot of data available yet. So a recent study found that in 23 out of 25 company submissions to NICE, the UK Health Technology Assessment Agency, expert judgments were included in some way. So then the question is, how do we make sure that we're soliciting these expert judgments in a way that is robust and stringent and kind of suitable to serve as evidence in the magnitude of decisions that are being made from this. So the work that I'm talking about is, sorry, previous slide still, please. The work that I'm talking about is from a project that was funded by the UK Medical Research Council. It was led by colleagues at the University of York, Laura Boyke and Marta Suarez, who will be speaking after me, as well as collaborators from a number of other UK institutions. And I'll be giving a really quick whistle-stop tour of some of the work, but if you'd like to dive more into the details, there's two publications I can recommend. The first is a health technology assessment monograph, which really covers all of the dirty details from all of the work that we did. But if you want something that's maybe in between the 10-minute talk and the 200-page monograph, there's also a short article in Medical Decision Making that covers some of the main work and findings that we came with. Next slide, please. Thank you. So in terms of methods used in our work, we had a few different approaches in order to identify suitable methods for use in healthcare decision making. We reviewed the available existing methods choices from other domains. We critiqued the applicability of those methods for use in healthcare decision making, and then determined appropriate methods choices. So the review of available methods choices that involved a mix of both systematic and non-systematic searching. We did a systematic review of all available published guidelines, both generic guidelines for expert elicitation, like the IDEA protocol and Cook's classical method, which you've heard about earlier. And we also looked at domain-specific guidelines, like those published by the European Food Safety Authority and other organizations like that. In addition to the 16 published guidelines, to kind of supplement knowledge about specific elements of the elicitation process, we did a number of targeted searches on specific topics where there's more individual studies that have been done, things like fitting and aggregation, heuristics and biases, things like that. And then in order to critique all of the methods choices that were identified from those reviews, there was a review of applied elicitation studies in healthcare decision making, which was led by Marta, who identified 21 different applications. And based on that, we came up with a list of the various kind of constraints that come into play when applying elicitation methods in healthcare decision making. We gathered experimental evidence on a few different components of elicitation and used that to develop principles for elicitation in healthcare decision making, which we then use as a basis for making recommendations about the various methodological choices. And all of this was kind of discussed and finalized in a final workshop that we had with about 30 different stakeholders from various different types of institutions and backgrounds in the UK. Next slide. So there's 9 principles for elicitation in healthcare decision making that we identified. Were based off of the reviews of the applied studies, the identified constraints, and also taking into account Roger Cook's requirements for the principles of rational consensus, which is also something that should be the foundation of an elicitation exercise. So those principles are, first, to ensure transparency in the elicitation, and systematic and transparent reporting both improves the validity of the exercise, and it also enables competent peer review, which is really critical if you're going to use elicitation to guide a decision-making process. The second principle is that the elicitation must provide useful information for the decision problem. So the questions need to be fit for purpose, and the elicited quantities need to be consistent with the types of parameters and structure of the model. The third principle is that the elicitation should aim for consistency, but it also needs to be flexible and respect that different decision-making contexts might have different constraints. For example, kind of a local decision maker might have different time or resource constraints compared to an international decision maker, and the methods might need to reflect that. Principle 4 is that the elicitation should reflect uncertainty at the individual expert level. Principle 5, that the elicitation should recognize and act on biases. There are a lot of relevant biases that have been discussed by many of the other speakers, so you need to make sure that the elicitation process mitigates against these. Principle 6, an elicitation task should be suitable for experts who possess substantive skills and are less likely to be trained in probability and statistics. So because of that, training is a really essential part of an elicitation exercise. Principle 7, particularly in healthcare decision-making, the role of adaptive skills is really important, because you might be asking questions where there really is no person who has detailed expertise in the specific quantity of interest. So it's about kind of translating knowledge in similar areas to that area. Principle 8, the elicitation should recognize and act on between expert variation. And then finally, principle 9, the elicitation should promote high performance of the expert. Next slide. So based off of all of this, we have some kind of high-level recommendations for different reference methods for the various elements that go into an elicitation. So in terms of selecting quantities, you should use simple observable quantities where possible. You need to be wary of independence where possible. Where possible, frame quantities in terms of independent variables. And the wording of quantities should be clear and in terms that are meaningful to the experts who are taking part in the exercise. And in terms of encoding judgments, both variable methods and fixed interval methods can be used, but should be consistent within an exercise. Selecting experts is something that some of the other speakers have talked about, and what we find broadly agrees with what's been said before. Make sure that you're representing the full range of expert beliefs. In identifying experts, you should focus on substantive skills, because some of the normative skills about doing an elicitation are something that can be trained a bit more easily. It's important to minimize and record any conflicts of interests, and you should include at least 5 experts in an exercise. Piloting and training are essential, particularly where you're working with experts who likely have substantive skill, but maybe not a lot of training or experience in elicitation and probability. So that's an important part of the exercise. Next slide. For the level and conduct of an elicitation, the belief should be elicited individually. And if there is any interaction between the experts after that, then it needs to be carefully structured in order to avoid the introduction of any new biases or group dynamics. So that's, again, kind of in keeping with what Anka was speaking about earlier. If there's between expert variation, then that should be explored. These kinds of exercises are better done face-to-face where possible, and experts should have an opportunity to get feedback and revise their assessments as well. And finally, around aggregation, analysis, post-elicitation processing, and validation. It's normally useful to have some sort of probability distribution that's fitted to the individual judgments. And following that fitting of individual judgments, there can be mathematical aggregation through linear polling, but there shouldn't be any sort of adjustments that is designed to reduce the variability between the experts, because again, that variability between experts is really important, and the reasons for that needs to be explored. In addition to capturing these quantitative values from the experts, it's also important to record their qualitative rationales for their assessments. And that can be a really useful tool to understand why there is variability between different expert assessments. And finally, it's of course important to clearly document and justify all methodological choices that are made. Next slide. So these reference methods are kind of by design meant to be flexible so that they can fit to the different contexts and constraints of the different settings where they may need to be applied. But they were also created kind of in the thinking about a UK context and UK health technology assessment context in particular. So some of us who are involved in this project are involved in some new work now with an ISPOR Good Practices Task Force that's also bringing in a wider group of people to think about how to develop recommendations for good practice and elicitation in a wider range of healthcare decision-making settings. But the bottom line is that for some of these elements, like the best way to instigate training to minimize specific biases or elicit dependent quantities from experts that don't have a lot of experience thinking about dependence modeling, more evidence and more practice is needed in that area to really define what the best practice should be going forward. So that's all for me. Thank you for letting me come and talk with you today.